change to make with a medication that seemingly has not had any negative adverse effects. So with that said, we could try, say, next week, after having done this for a while, in my pretend PDSA cycle, trying with, say, the next 10 patients, because we have our lifetime's worth of experience with morphine, where we would switch them on to that using the dosing that we know through protocol and other studies is appropriate, and see if, assuming that there's no negative impacts, if it does in fact decrease the amount of time that they are on these medications, as well as if it decreases their length of stay, and then if there's any negative impacts in their symptoms, which we already measure by nature of what we do. If that was the case, it would mean that we would be giving medications for a less period of time, and a medication that's given at a less frequent rate because it lasts longer in the blood. And I think if there was a change that was positive, we might learn that in fact this medication that is used elsewhere regularly is maybe a way that we should move towards having a positive impact on both the kiddos, but also the length of time that kiddos can spend with their parents and families more regularly would be sooner, as well as ultimately getting them out of the hospital, which in NICU is not a small amount of money a day. So those are my 2 cycles, though arguably there would be a lot of small cycles in between.
This might be going more in a little bit too far into a research sheet. Do you think that like 10 patients would be enough to be like, hey, this is better, or would you really just be making sure that there are no adverse effects, and then looking kind of like what Shannon did at like 3 or 6 month intervals to have more, they come in waves.
So I picked 10 arbitrarily, but in general, I admittedly find some of the PDSA numbers a little arbitrary as it is. But ultimately, you do it, and then you continue to monitor and see if you're finding changes. So if it continued to be good, then you'd keep going, and then if there's something that came up that was a worry, then you'd switch. But that's the difference between this whole QI versus on the research front. My hesitation with that is, as we're going to learn this afternoon, this has been done, but it hasn't been done enough that we can say it definitively. So I feel almost like it's a missed opportunity to then do a research level study that you can then both explain why you're continuing or not. But the one thing you could do arguably is compare against neonate units elsewhere, or retroactively look at what's been done up until now, which would be ultimately a very good comparison group. So that might address the question, but your point's well taken. I mean, I picked a really legitimately arbitrary number, but really it's a kind of a do it with 1 or 2. And I think 1 or 2 is not enough too, because maybe you just had a really sick kiddo or someone who's going through a great deal of withdrawal, but you need to have enough that you don't see. But sorry, you wanted to say something?
No, John.
Okay.
I just have the use of a new medication is obviously something where you could theoretically, and I don't know the research, and I think you're going to tell us about it later, but if there's a really great RCT that really shows that this is a beneficial medication for NAS over the use of morphine, and we're saying we want to implement it at our center, at what point would you say, I believe the RCT so much that despite the fact that I'm not seeing a difference in my PDSA cycles, I'm going to continue on this?
Yeah,
I think that's an interesting decision you have to make of oh, when are we going to say, oh, it's not working and it seems more dangerous than morphine?
So what did you say? Did you learn anything from a tool that might help you judge the number of kids that you might like to assess? Thank you. Exactly. And so, but just because you're doing a quality improvement doesn't mean that you don't incorporate a sample size into it in terms of saying, because if you don't see it, maybe you're underpowered, maybe it's not there at all.
But there could also be other issues with its implementation.
For sure. But the thing is, that's part of it.
And it's also knowing your population. So these kiddos, it's different if you can just manage what the kiddos are coming in with, but their parents are the ones who have created the scenario. So in Ontario, what moms are treated with is this kind of medication. So maybe those kiddos would respond better than most of the moms here are treated with methadone. So, and there's, it seems like evidence to suggest that it works either way, but we don't know. So there could be other variables. But yes, moral of the story, if this was actually happening, which I actually like it too, I would want there to be a number that makes logical sense, because otherwise I feel like it's a missed opportunity across the board.
And so would you do sort of the headphones and the medication change, or
There are 2 separate cycles. Yeah.
Or or you could almost do it 3 groups. You could do and see if there's a synergistic effect by having both added on.
Right, and so I think again, like, and this is where the PDSA comes in handy. You have everything before this, and then you would have what is with headphones, and then you can have what is with headphones. If there's a positive change, what is with headphones and this. And so ultimately the headphones aren't going to change much of anything, I would guess, though I think could have a huge impact. It is really loud in the NICU, having worked there and like listened to the nurses discuss like how painful like it is, and you guys will explain. I love being there, but like,
do they have
if I was a kid, I would see
noise lights in there?
Pardon?
Like I've been in NICUs where they have like a light on the roof that actually changes color if you're being too noisy.
No, so this is what I mean. Like there's tons of things you could do in that space to make it less loud but they're moving. But that said, even then, like, it's still. I mean, we had kiddos in rooms individually, and it's still loud when someone down the hall screaming.
Changes, and then everyone sees it, and they're like, "Oh, we're being too loud."
Yeah. Which is just hard though when you're in a room full of screaming children, because like all these kiddos are screaming and they don't color the light is like they're just.
And then
yeah, for sure.
To be swaddled, to put the headphones on for like patient safety.
No, they just kind of sit on. It's like, you know the ones that kiddos have at concerts that are just like a head.
No. Then say they like move.
Yeah, it's not. And most of them are on monitors anyway.
Yeah, no.
Like the same reason they get to sleep on their front. Because they're on monitors, so. But these are all very valid points to monitor if we were to do it. But.
No, I think you chose a very, oh, do you have a point too? Sorry, have you?
No, I was talking like he's talking about safety and moving. Like physiologically they're not able yet.
Yeah, no, but it is something you should consider. I agree. Yeah, this is a very good topic, and I think you thought through your cycles very well. And we had a good discussion about this. Can
I go back to this morning? We talked about interactions. Interactions are also synergy, so that was an excellent, so I don't know whether you kind of think about it, this is that 2 components may be synergistic after what the interaction is, but it's sort of a vague concept, so we can.
All right, so we're gonna go back to discharging patients from the ward. I had similar, actually my plan, sort of my goal was to discharge 90% of patients identified at handover as being ready to discharge prior to noon, and came up with an arbitrary number of 40% that we're currently meeting that standard. And similar to what Duncan had said is that if patients are discharged sooner, we'll have better patient family satisfaction, we'll be able to pull patients up from the ER, and we'll have more efficient bed turnover. The people involved would be, in my PDSA, primarily the house staff, the attending and nursing, with housekeeping and bed managers involved in a bit of a peripheral point of view. And I looked at a whole bunch of barriers to the actual discharge process from the wards team point of view. Some things that could be done sort of overall would be to identify potential discharges at handover, making sure that potential discharge patients were examined prior to formal rounds, start the rounds with the potential discharge patients, print the medrecs prior to rounds rather than writing an order during rounds, and then filling out the discharge summary while they see the patient. And the one that I wanted to focus on first was printing medrecs prior to rounds. Because what I find is the process now, most of the time, is that during rounds, you'll write like discontinue IV, this, print medrec, etc. Then the chart goes, and then you finish rounds. So the medrec is not actually printed until 11:30 to 1 p.m. at some point, and then you have to find an attending or a PA, someone who can actually sign it, because you can see it, and then that doesn't do anything. And that just sort of adds on to it. So the first part of my cycle is that the house staff will print the medrec prior to the round. So rather than write an order and put it in the chart, and even if you give it to the ward clerk, they have other stuff to do and it'll get printed and that's sort of a delay. I'm sure, I haven't figured out exactly how to print them, but I'm sure it's very simple.
So Dr. Lee showed Carrie how, like, from our laptop on our cart, he could print MedRecs.
So at the we'll make a slight adjustment. At the beginning of rounds, so when you get there, you pull up the patients who are going to be discharged and print them all off. So that's sort of the intervention. And in my hypothetical PDSA, we observed that when the attending was rounding with the team, 100% of the MedRecs were signed during rounds, but not necessarily before 11 a.m. Because we're just focusing on MedRecs and not sort of changing the order of rounds at this point in the cycle. And then when the attending was not rounding, the time to sign varied by provider, but 75% of them theoretically were signed before 11 a.m. because the attending would just go on their own time to sign them. And with this observation, or with this intervention, 55% of my patients were discharged before noon. And so the biggest thing that I learned was that time to discharge varied based on when the patient was seen by the rounding team. So cutting down the time from like time seen to time discharge was there, but in terms of meeting the before noon goal, that was not enough. And so my future next cycle would be to start the rounds with your potential discharges. And I know there's, it would be a discussion with the charge nurse who is rounding with the team and coordinating different teams, but I think there are, compared to the number of patients on the service to the number of people being discharged, I think it would be feasible to either update the charge nurse or I think we could get around having teams on the same floor for that purpose.
Very good. Very good.
I know we had a large discussion about this already.
Well, I think you should work together and then find some way, like, why don't you just discharge them all on rounds?
Or you like call your batch, I guess some consults you need to ID, but call your consults before you leave the floor.
Yeah.
We often did that. We used the like
We would always call when we were rounding.
to call while we were rounding
Yeah.
to let people know about consults.
They are like, you're gonna be green, yellow, red. The consults don't necessarily know what color they are, and the rooms aren't up to date. But either way, if you're switching to yellow, to Lex's point earlier, you can say, you know what, you're gonna call that consult service in the afternoon, say tomorrow, or in 2 days we're planning on discharging. Can you please come by and let us know what you need? What we need is this. Can you do it?
Not all of them will call you back within the time of rounds.
Yeah.
True, but these are, that's a start.
And that's the other thing, like if you call them at rounds, you've probably moved on to another patient or another floor by the time they get back to you. But calling,
that wasn't a negative thing for us. It was still,
like the one thing that deterred was if people went to use like physical phones to call, because then they weren't around the rounds. But if you like paged from like the cell phone that we're supposed to use, or from your own cell phone, and we're still able to round, and then like when they call back, you can just like be right there. That seemed to work.
we always tend to have just one person generally be the caller, so that too, if you get a call 3 patients down, you still know that you called neuro about person X, and that's why you're calling. So when you got the phone call back, you could actually have an answer versus
Or
being like, I
depending
don't know.
on who's presenting, like whose patient it is, someone else might call. That's kind of how we ran it. Or sometimes, often Cheryl would call a lot because she knew people.
But who you know.
No, it's true. Like surgery, you call the surgical nurse and you'll get an answer in 10 minutes. You call surgery, you're not gonna hear back maybe ever.
you'll get the med student who will come.
Well, but if you could show that some sort of process works like this, then sometimes it provides even an incentive for the other services to compete to be better.
Oh yeah, and in mine, I was starting with one service for 1 week,
Yeah.
and then before.
Yeah, that's great.
Out of curiosity,
Yeah.
small tangent. What do they do at Toronto, Dal, and Edmonton when you did inpatient peaks? Like, how do they discharge?
For discharges,
And yeah.
oh, it's just as disorganized as here.
Yeah.
in Edmonton.
In Toronto too. Just as well, and the other thing is that like here's the only places where like house staff don't write discharge summaries.
Yeah.
And so like that is just a whole
And
other
even like
thing.
signing med recs.
Well, in Edmonton, residents can sign med recs, so that helps.
That is
a
the thing I
little
do
bit.
find it challenging, and we can't sign.
And then
everywhere else
like
you can sign it.
residents can fill out the discharge.
Right,
They can do the whole discharge themselves, pretty much.
So there isn't a model that you could.
Well, but that's actually a good thing. There are some other places like, I think like Calgary actually had a pretty good model when I was a med student, but that's a while back now. You had to, well, as like the medical student or even the resident, you had to fill out the discharge summary. And then, but there was a whole bunch of interventions, like even rounding had to be done and was actually done by 11, which was interesting.
And I think it's like,
But it's doable, right?
yeah, and we fill out like the discharge form.
Yeah.
The service I've been on fills it out. Either sometimes the staff will do it before rounds, or the senior will do it before rounds, which is always really helpful, or we'll fill it out as we go along. So at least that's been done.
And the discharge form, in fact, most of it could be filled out on day 2.
If you,
Like,
or,
most of it's
if
like,
you're-
why are they here?
Yeah.
What day did they come? What medications were they on?
Yes.
What major
Like
procedures
in
did they have? Like,
NICU
I filled that out week
Yeah,
before.
in NICU, they want you to update, like by the time they go home, their discharge summary is pretty much complete
Yeah.
already.
Yes, and that's also what the model was in Calgary, for example. Like you had to just update it every day as part of your,
Yeah.
which is something you could try.
Yeah. And then you're less likely to miss things.
And I can guarantee no inpatient attending would be mad if you wrote a summary, because then they can read that to the
Yeah.
right? Like it's not, I don't think, but you'd have
Or
to discuss it. Yeah. It is. But it is.
It also changes a lot of work though, right? Like there's tons of things we spend time doing right now that if we didn't spend time, we'd have that time to do something else. So like why when a complicated patient is coming from surge or PICU or wherever, are the people, like residents being told at 4 in the afternoon that really complicated patient's coming to, and I mean, but I'm sure other people knew, but like the people who have to write up that summary, like I stayed till
Or
8 or
your
9 on really
PICU
complicated patients
transfer is
going
coming
through.
at 5.
But imagine if you have all that time, then writing a little summary is nothing.
Yeah.
Like, that's not a big deal. Like, that's an easy, here's my one sentence for the day, and here's my other sentence.
Amazing, like having an admission in the afternoon, how just like changes your whole.
Yeah. Well, it's amazing what being done rounds at 11:30 rather than 2:30 would do.
Would you live?
Like, it makes a huge difference.
Yeah, well, and this is demonstrating.
Which is why it's a great job project.
Yeah, it's a very good project, and it also demonstrates how doing these things can impact the quality of life of all the team members, including you guys,
Yeah,
right?
not
Like,
just
And one
yeah.
indirect measure too potentially could be the amount of people missing 12 to 1 teaching.
Yeah.
Because rounds are longer
Oh, yeah, that's good.
for the education.
Including people who are supposed to present sometimes.
Yeah.
Which Monday teaching is now supposed to be protected.
You know, so like
But even
not-
still, do you stop rounding at 11:50
No.
for an hour and then come back to finish your last couple patients?
I missed over
If you're
60% of
protected?
teaching.
See, we didn't, but that was just because they made it a learning.
Yeah, but
I just happen to be on, have 2
Well,
attending super fast.
yeah, I think that could even be an extra added on. I think that's a very good idea.
Like, that's a good way of measuring.
yeah, to see like if
Yeah.
rounds are
If you're writing forms at 12:30, you're not where you're supposed to be.
Yeah.
Like, yeah. Good job, guys.
Good job. Yeah,
It's
great.
really good.
Favorite topic is
Alexa's,
Okay. So, I've talked to you guys about this before, but.
Not me.
Not you, yeah.
we talked about
So
it last
coming from Edmonton, and other people have seen this coming from their hospitals, we use a very different vital sign sheet than is used here, called BPUs, which stands for Bedside Pediatric Early Warning System. And I kind of put my project around whether or not that could be implemented here, and kind of what effect that would have, and if that would potentially reduce transfers to PICU, things like that. So that's kind of the general idea, is if we can implement BPUs and how that would change outcomes on the wards. So the plan was to implement kind of a pilot project where one ward initially would use a new vital signs record, that being the BPU's record. If you haven't seen it, you can Google it. It's like, there are different ones for different ages, and then it specifically color codes like the out of range vital signs for that age group. And then, so you can very clearly see like, oh, this kid's heart rate is in a range that is not appropriate for their age. And then you can also, what it has is at the bottom, the nurses can calculate a score. And then depending on the score, that kind of tells you where they are in terms of like their overall picture, I guess, in a more objective way. Yeah, so that's kind of what it is. And so the plan would be to implement it on one ward initially for assessment of patients admitted to that ward rather than the regular vital sign sheet. And the hope of what it would produce would be improved outcomes for children in terms of early recognition of a deteriorating status in order to implement treatment sooner or reduce potential transfer to PICU or other invasive interventions. And then also that it would help clarify communication between different disciplines. So if nursing would then have a very clear like, oh, this kid's score is this, and that would be a more clear communication to like the medical team rather than just saying I think they're unwell or I think they're deteriorating, which is sometimes difficult to interpret. Other things that they often do with it too is depending on the score, there are specific protocols for what you do next. Like if they have this score, then they need to be assessed by a physician, or if they have this score, then whatever. And I think you could also potentially implement in terms of that, this is a bit of a tangent, but like if they have this score, then maybe an RRT should be called, or you should consider an RRT, or if they have this score, you should use the severe sepsis tool to see if they meet criteria for severe sepsis. And so I think those are two, because the RRT and severe sepsis, people have talked about how we have them, but they're not being used enough, and so this could potentially be a way of increasing those tools as well. And then steps to execute would be, I kind of focused my cycle around what would probably be a later cycle. I didn't do in-depth of multiple cycles, but I think initially you would have to do kind of cycles where you train people on how to use it. You could maybe even have like a grand rounds presentation on what it is so that people are aware of it, and like the prior research so that that could be disseminated. And then I think like some of your initial cycles you could even like say, okay, we're gonna teach like these 5 nurses to use it. And then for a week, maybe those 5 nurses use it on their patients and see kind of how that goes. And then they can give feedback on what they like and what they don't like, and kind of including those players. So you definitely have to include nurses, residents, inpatient staff, all in kind of this process. So in terms of in the cycle I'm specifically working on, I think it would be a later cycle, like maybe 2 or 3 or even 4. You would implement BPUs for all patients admitted to one ward. And I picked CH4 because CH4 to me is like the more acute ward, and they have like the observation room, and so I think it would be particularly useful there. And give training to all the nurses on CH4 as well as all residents and staff on its use. And to study this in terms of like what I would measure, so I'd want to measure you'd have to do it before you do it as well, like how many kids are transferred to PICU from the ward, and then after you implement it, how many kids are transferred to PICU from the ward. I would also want to measure like the number of RRT calls and the number of times that the severe sepsis tool is used, and I think that those would actually increase, hopefully, because you'd be detecting kids who are deteriorating sooner and using those tools and implementing appropriate treatment for them, and then hopefully the PICU admissions would be lower because you're using the other tools.
Codes.
Yeah, and codes would be less, measuring codes as well. So, and then I think in terms of like what would happen just in my theoretical PDSA cycle, nurses might say that there's a little bit of increased work with filling out the sheet because it's a little bit longer, more extensive, they have to calculate a score, but that they like the clear protocols and specific guidelines on when to call medical staff, and they're more reassured by that. And then physician feedback and resident feedback, I think they would say that there is nicer visual for tracking vitals, gives more warning on patient status. And I think in particular, it would be really good for off-service residents who are less familiar with pediatric vital signs, and they can have a very clear look at, okay, this is an abnormal for this age group, and it would be really useful for them. So those are sort of my measures, and then after that, we could kind of look at the different feedback and work out the different kinks with using the tool. And then next steps would be further teaching and training on how to implement it in all the wards, so it's kind of consistent across. My other pet peeve is that right now different wards use different vital signs charts, and I think it would be useful if they were all the same. So, yeah, that's my cycle.
Like, how much do you consider doing this for your actual facility project?
I'm very seriously considering.
This is such a good,
It would be a very good project.
such a good.
I mean, we've all talked about it before,
Yeah.
yesterday with Mary Ellen, and then like also, I think we talked about it during one of our like half days, right?
Yeah.
But one of the things that I have thought about in regards to this question, or like while you were presenting, is one of the outcomes you could look at was how often an abnormal vital sign was missed. So like, it would be a chart review, but like, you can
Like
go
plotting
through.
current vital sheets and plotting them onto the new ones to see if they were.
Yeah, or I think
you
a
go
lot of
back and
times
check.
people have like an elevated rest rate and like no
No
one
one
makes a
does
comment on it
anything,
or does anything about it at all. And it's like one of those like things like early sepsis, like no one notices because it's on a vital sheet and they're not contextualizing it properly. And this might help.
I think doing a review like that would make sense, but like, you have to remember too, like there's all the times that someone's picked up a phone and called, or like we've got a call and nothing's written on the.
Often it says nurses' services provider.
Yeah.
Yeah.
They usually write it, to be honest. It's one of the things.
Oh, I've
they
seen
usually write.
not too, but.
Yeah, you could look back and see, like, if you're doing a chart review, look at, like, when the RRT was called, or if an RRT was called, or, like, because there should be some sort of documentation of, like, after the fact, someone write an entry, like, we called it code blue, or, like, I came to see and did this and this
Yeah.
and this.
And I think there have, based on what PI have said is that, like, when codes are called, people go back and they look and they see sort of the progression. So there must be data information somewhere
Yeah.
that shows what's already.
Which would highlight another discussion point of that we are very good at documenting currently codes and RRTs. It has been suggested and really proven all the time.
Yeah, it's another outcome measure you could see if you, like John said, if you found abnormal vitals where they documented versus when you introduce the new sheets, then where they documented.
Yeah.
Maybe you want to say something, we keep it on.
No, I was talking like, if it could be like an individual based chart, like to decide the 99 percentile for like hypertension, other parameters. It was like electronic.
Yeah, if it's electronic, you could do that, but I think the whole point is that you have to block people in some way that you don't have 30 million charts.
I guess my only content suggestion is when you talked about like thinking about implementation with like nurses, I don't think it makes more sense to do by patient, because otherwise like a different nurse is gonna come on.
Oh yeah, for sure. Like, and then they need a different chart. Yeah. I guess I was just thinking it'd be easier
Or like,
to train
or if
certain
you train,
nurses.
if you train a floor and then implement a couple of patients, or train, however they do patient assignments, you can ask the nurses on how they,
Yeah, which would work better for them.
how to, like if you are gonna do these 5 rooms, which nurses, because nurses will often follow the same patients, like
Yeah.
if you need.
But like depending on their
15 nurses.
schedule and if they're on nights or if they're on
Yeah.
days and they switch halfway through.
No, very, yeah,
Useful.
very good job. This happens to be my area of actual knowledge. So, and happens to, like, I have worked with the creator of this score quite a bit. So, the outcomes you chose and you all talk about are actually what the score was designed to look at, which is to reduce urgent referrals to the PICU and deteriorations or code blues. Initially was designed to try and reduce cardiac arrests, which is a rare event, so it's a bit harder to do that, but you've hit on a lot of the major outcomes, and that this is actually something that I've been, one of the things that I'm developing in the hospital, so if this is actually something you are interested in, you can talk to me about it.
Okay.
This is on board.
I was gonna say, I am very interested, but I'm like, is it feasible?
Yeah, I
in a
think
residency
it's
project?
totally
And I need to find a supervisor.
No, it's a very feasible one. Yeah, so we can talk, because this is actually, like, I don't think you were at my presentation for my, like, none of you were there, but this is what I've presented on to the hospital before too. So it is actually my area of knowledge. So no pressure, but you can talk to me after.
Oh, pressure, you're doing
Otherwise, someone else.
Or else you're gonna have to complain about it.
One of them didn't take it.
But no, but this is, yeah, I think you hit on all of the very important points, and the way you design your implementation is very similar to the way the initial studies were. I don't know if you happen to base it on those or not, but that's a lot of the ways that they implemented. The person who created it is also an expert in healthcare quality, so it's a very similar model. So yeah, very good job. Sweet. Yeah.
I don't know whether two people are filling out forms.
I filled out one.
I don't know if everyone will get two.
I'm just getting my water.
Everybody get one. So somebody does.
So I filled out on Jesse.
I filled that on Robin.
So I got one on Suzanne.
I did Suzanne and Jesse.
So
I'll do Linda.
So Jonathan.
Okay, so no one's like Karen yet then? Because I could be Karen.
Or I can do Karen too. All right, Karen.
Jesse, did you fill out a
I've done
ballot?
both.
Yeah,
Who were yours on?
You and Duncan.
Okay. So James, is then missing somebody?
I will fill one on James or Linda.
Okay. And then.
I can do
Sorry,
I can do Habib if he goes.
Okay. And is anybody done on Jonathan? Sorry.
Yeah, someone,
Yeah, that's what I thought you said. I wasn't sure. So are we covered with everybody getting one?
No, because I only have one sheet left, and
Well, I got one sheet.
James and Linda both. Okay, and then I can do on James. That works.
We've got lots of sheets here.
We figured it out. No, that's okay.
Oh, you don't?
Sorry, James is gonna do Linda.
Okay, so we're good. Thank you. You're doing a very, very nice job of feedback. You started off doing a nice job of feedback, but I think your feedback is becoming more specific and very helpful in terms of positive, but really enhancing the projects too, and all of the things. You're getting feedback.
Yeah, that was great
feedback.
And I'm sorry if I'm being rude. I felt a little hype with my singing.
Oh, no
Apple,
No worries.
as we're talking. Okay, good.
So the context for my project is, so right now for neonatal resuscitations, there's a specific room on the second floor in a women's hospital where they have basically all the equipment. Like that's where they have the ventilators, that's where they have like basically all the equipment for resusces. But all the deliveries, as you guys probably know, can happen anywhere. So like my idea kind of stemmed from this experience where like we were in the IMC and then we were and then an obstetrical tourniquet was called on the 5th floor of the women's hospital. So we ran up there. A 25-weeker got delivered on the 5th floor. And then thankfully there was like a bed on the 5th floor for like neonatal resuscitations, but they didn't have like all the equipment and no one knew where everything was. So it was like a very kind of a more disorganized resus because we didn't have all the equipment and because no one knew where everything was. So then like my PDSA thing was to improve kind of neonatal resuscitation outcomes for neonates that's kind of born far from the resuscitation room. And my outcome measure was to have something more concrete to measure was to decrease the time to transfer to resuscitation room by 20%. So the actual resuscitation room on the 2nd floor. Because like, so how it works is right now is wherever the babies are born, they go stabilize, and then once they're at least like stable enough to be transferred, they'd be transferred down to the 2nd floor, like actual recess room for like actual recess. So that's kind of my proxy for like improving, like for neonatal resuscitation outcomes, is the time for transfer to the 2nd floor actual resuscitation. That kind of makes sense. So the steps to execute is for my step one would be to start with the antepartum floor, because the antepartum floor is where they have all the high risk obstetrical cases. So that's probably where most of the kind of the highest risk of having like an unexpected delivery. And so first of all, step one would be to have a fully equipped resuscitation bed on the 5th floor itself, with like portable vital machines, with like proper I'm not sure what those like bag valve masks are called that anesthesia uses instead of the typical bag valve masks.
They're just flow inflating bags, if you want to use the generic term.
Okay.
Or I think you call them here JR bags.
Okay.
Jackson Research.
Yeah.
Brand name.
Yeah. Okay. Yeah. To have all that equipped. And then maybe step 2 would be to simulate like a similar layout around the resuscitation bed as like the layout around the resuscitation bed in the 2nd floor resus room. So at least the nurses and all the staff that's running the recess would know where things are, sort of. And also, like step 3 would be to have, say, like a training or refreshing session every 3 months to orient everyone to where everything is. Just so we're not like scrambling to look for things during the actual recess itself. And then so for the hypothetical situation, just having like a recess bed itself, like a fully equipped one, on the antepartum floor itself decreased time to transfer to the actual neonatal recess room by 10%, but it was difficult to simulate similar layouts because the rooms itself had different layouts. And so because of that, so like I guess that's what like step 3 was for, to have the regular refreshing sessions for all the staff involved in resuscitation, to kind of orient everyone to where the things are around each of the resuscitation beds, so we're not like scrambling in the actual recess.
Just a challenge I think that would be moving forward is that while you can have births on every floor, they don't actually happen that often. So even figuring out ways to check the system without it requiring an actual babe to be born on the 5th floor might be a good addition to your approach.
Yeah.
So like you could do a simulated code blue neonate and see how people respond, and then change the way the room is and see if they are able to move faster and do better, you know what I mean? Because I think the catch with any of these things when they're not regular occurrences, it's hard to then know if they work or not. And that way you're not risking any danger or change to a child when it does happen, but on the flip side are able to know like, oh, wait a second, that was way faster.
That's true.
Which you might know, but then you can say without question.
Almost like the simulations that we did yesterday, where you run the simulation in the current environment, ask for changes to make it better, rerun the simulation.
Yeah.
And yes, there's improvement that comes from having built the simulation before, but all the people you're using are well-trained resus nurses.
And you're not trying to practice like getting the airway necessarily, you're trying to practice like getting stuff to get the airway or getting to go to.
I just had a thought about your like outcome measure, because you're going to measure like time to the actual recess room, which is going to be impacted by like the stability of the child and like all this other stuff that I'm not sure would like accurately reflect the small changes that you're making in terms of like how well the team's actually set up. And then also like at the extreme of that, there's like scoop and run where like someone's just like, nope, this room isn't good, we're moving. And like you would have someone with a really short time to the recess room because the other room was actually not adequate at all.
And a lot of times with the planned deliveries, when they expect more, then they'll scoop. So they get to the recess room faster when they're sicker.
Yeah.
Yeah, so if it's a planned delivery, they would be on the second floor already, so they would be born by the resuscitation room. This is more for like, I guess, more unexpected ones where
Sometimes they go to the other side of the second floor, and that's weird. That stuff is different there.
An interesting add-on could be even just, like the number, we were talking about this yesterday, when you call an OBS and you know that they are with child and the child is likely going to need to come out, there's no reason you don't call a code for the infant at the same time. Whereas like, we talked about this, like often we were running to codes because you know they're gonna call, and then you're halfway there, they call. But imagine if you actually did what the code was, well, you'd still be in Yellow Deer when you are needed in. So like, that would be an interesting one to add, because if you get to the room sooner, you can also prepare it better, even if it's not your normal room, versus rushing in.
Because how, the baby, when you guys went, had the baby born before you got there?
no, it was born like a minute after.
Right, so I like
That would have made a difference,
Like if
'cause-
you knew right away, I mean, for this one in particular, you guys ran anyways, but it does give you extra time.
Yeah, I think that's a really good topic and good assessment of it. It's that you're talking about rare events, right? And having a team who does the common events all the time and then putting them in a different environment. So yeah, I think some of the suggestions you got about doing simulations in that environment is really going to be valuable to this kind of project, because as your colleagues have mentioned, the people know how to do a resuscitation, but if you change the environment just a little bit, it throws everybody off, or it could. So learning that is going to be really valuable. And one other challenge will be thinking if this is something you want to go forward with, is it's going to be a totally new environment if that women's hospital opens at some point. I'm just kidding. And they were building that for so many years, but I think it's almost done, right? So that could even be something you could actually think about, because it's going to be a brand new environment, and the teams there are already not going to know this environment, right? Like the teams that work in T1 now aren't going to know that environment. So this is something, if you were interested in applying, it would be a good time to be applying. Yeah, good job. We had 2 left, right? Yeah. Good, you have enough time. Excellent. This has been very interesting so far. No pressure.
Okay, my topic is a little bit different. During Ask rotation, I was sitting in the ER. I saw like 2 patients. They were waiting for almost like 25-30 minutes for a translator. Both of them were speaking Arabic, so I went and translated later for them. So my project is, instead of overhead calling for a specific language, why don't we sit like with the hospital administration and see which languages physicians or employees in the hospital speak. And at the same time, we'll have a schedule of every physician or employee, when is he working during the day. So we can directly contact that physician or employee for a specific language instead of overhead, which will take time. Plus, like, no one will respond, believing that other people will respond for the. So, from what I have seen, like almost like 35 to 45 minutes, the patient will stay in the ER. Also, I noticed it in the outpatient, but my focus now is in the intensive areas in the ER. So the intervention will be, instead of overhead calling, we will contact directly those people who are able to speak these languages and ask them to come to translate if they are available. We have to measure, like before starting the project, specifically in the ER, how many minutes will it take for someone to respond, and compare it later with the direct contact, and I'm expecting it will be lesser time. The main obstacles will be like, maybe this employee is not available or he's not willing to come. So we have to like make sure like those physicians or employees are having the time for sure, and they are willing to do these things. That's it.
Okay, great, good topic.
I think it's interesting, like, I know, and Jonathan and I were kind of talking about this, like, there are services, like interpreter services that like should ideally, in an ideal world, always be available, like via phone, via person-to-person, you know. But you're right, it just isn't. Like, we hear overhead announcements like literally every day. Does anyone in the like Divergent staff speak such and such language? So like, my question is like whether or not like it's more valid to try and like make those services like as best as they can be versus like taking people away from jobs that they're actually trained and hired to do, you know what I mean?
Yeah.
Like if a doc, like a pediatrician is going to translate things like that, doesn't seem like an appropriate use of their skills. That said, like I mean, in some cases it's necessary, and obviously it's a really cool way of using skills if you are the physician that's actually like there and seeing that patient. Obviously that's really awesome. Like if we all spoke 20 languages and could communicate, like that would be really cool. So I'm just wondering like what your thoughts are on that.
Yeah. Good point.
It's interesting. I know of 2 nurses off the top of my head on one of the floors who have gone in the past, but they don't go anymore when they're called. And part of it's like not that they don't want to be helpful, but they're like, I might be able to come quickly, but I can't stay for 4 hours. And there's no even guarantee that when you get there, they are ready to have you there to answer their questions and all those kinds of things. But I think Jesse's point's well taken. There are some phone services that are actually really good, and I don't think Winnipeg uses. I don't know. I'm guessing based on what I've heard overhead that we just don't either fund that or use that.
It depends on like what the like environment is, because in the ER rooms you can't always like take like a hospital phone that would like be connected to the billing service. Whereas in like some of the clinics where you have like a phone on your office desk, it's a little bit easier.
Mary Shevey even did that. We're in the middle of nowhere.
I did use a translator in the ER once over the phone. It was like one of those like brick cell phones that they have. But I find using phone translators so frustrating. I don't know if that's just me. Like it's very hard, like a person on the phone, and then like they can't really hear you well, and like in the ER the service is crappy too. And then you're like talking to the phone, and then the phone talks to the person, and it's like I
mean, I think you lose that person piece, but arguably, like there are better services than others, and there's ways to make it so that you can hear well. Whereas, like grabbing some person off the floor who maybe isn't certified a certain way to be listening to personal, like, or is maybe part of that small community. So, like, if you're pick a population that maybe doesn't like to use blood transfusions, and the only person in the hospital is someone from your community, and they're there, and you want to say, I want a blood transfusion, but your whole community is in the room by nature of, even if they're going to keep it private, like, there's all that kind of stuff too, and sorry, it's my like mini rant, but I think there's a lot of possibility there that we as a...
In Toronto, we had these, like in the emergency rooms, we had these like speakerphone things on rolly things.
Yeah,
Have
like
other people seen those before?
Well, yes, but also in Toronto.
I've seen things like that in clinics, like here, but not in the hospital.
And people say it costs a lot of money, but you're like, the time spent taking away or keeping someone sitting in a bed that you're not using costs a hell of a lot more than having
and all that sort of like coming and not being useful right away.
And it's like short term versus long term. Like I just need to know if you're allergic to anything. We can have a social discussion around your history tomorrow when the interpreter comes in, but like.
But Google, like there's Google Translate, we can speak into it.
Which is horrible, but I've used it before.
Like, yeah.
You're not kidding.
But then you get a quick answer that's pertinent to the patient. Like, better than calling overhead.
The cases I saw when they are like the nurse was thinking about a diagnosis, and it became a totally different thing. So.
For sure. Yeah. I mean, communication is central to healthcare, right? You can't communicate. It's such a difficult issue.
Well, yeah.
And assumptions?
70% of everything we know is from the history, often, right?
Yes.
And you're right, if you can't get it, then it's really challenging. And this is a huge topic because the world is becoming more and more multilingual, and imagine how scary it would be to have your child coming to a hospital and you don't understand a word. Or, I mean, maybe, I don't speak Arabic. I wish I did, but I mean, these languages are more and more common. But I think your colleagues brought up so many good things that you could consider adding into your cycles. This is something that I think one suggestion would even be look at what are the most common languages, like what you said, but then should that be impetus to hire more translators for those languages, right? Because maybe you don't have someone for Icelandic here, for example, but probably Inuktitut, right? Like, because this is more common. So this is a very interesting topic, or is a phone going to help? Because you're right, it's not as personal as having an actual translator, but it's better than not having a clue what they're saying.
Or safety ticks on
Google search.
Yeah.
Also, like,
Yeah. And maybe we need something else new entirely. Yeah, go ahead, sorry.
well, like, it's also now even in medicine moving forward, like Matt Betty, when interviewing in Florida across the southern state, the first question I asked him was, do you speak Spanish? And then they don't. 20 plus of their population is Spanish speaking. They don't speak a word of English. It's like, well, you're not going to be used to us if you can only see 8% of the patients.
Well, we also like live in a new, like, Winnipeg hospitals, not so much technologically, but there's no reason, like, if it's a case of seeing, like, you can Skype a conversation, but even then, like, that's a pain. I don't know if you guys have done telehealth, but sometimes it's really helpful. Sometimes it's infuriating.
Yeah.
Sometimes there's someone there to translate. So, like, I don't know, nothing's perfect. It's how you set those things up to be successful. But
You're correct. Medicine in general is quite behind in using technology.
Yes.
This hospital doesn't have electronic medical record, for example, so you could say it is a bit behind other hospitals, but there are things like the NICU with that telehealth that are more advanced than other places. So there's lots of room. Yeah, great job. James, I think it's you.
Are you finding this useful?
Yes. It's just like
It's fun though, but it's fun when we're not going to make half of these changes.
Well, you'd be
But there's no reason we
surprised.
couldn't.
You'd be surprised.
I was on my cell
I was gonna say, there's no reason we all couldn't say, like, short of ones that are just
We'll
too
just
big.
all do QI questions.
No, but I mean, it's not even, you don't have to necessarily do all of it. You find a champion in the department who's on board with you and you say, here's a really great
Here's my
idea.
idea.
I'll give you the first 10 things. You just have to suggest them and put your name on it. And they say, awesome. And you say, cool. And then, like,
It's almost like a more like rewarding and like actually like in fourth year, here are the changes that you made to the hospital.
Yeah.
When you
and while you're waiting for all your ethics, like, you can send it, like, there you go. You don't need ethics for this stuff usually, hopefully.
Well,
Unless you want to publish it.
Unless you want to publish it, but even then, depends.
and also, this is the beginning of your careers, but the things that you're talking about now, as I just told you, have been issues that when I was a resident, and probably when you were a resident. Like, these are not things that have gone away, and the things you think about, and the more you critically think about these things, you could impact it for your whole career. It's not residency, you're learning a lot of things. This is one thing that you could delve into more, but you can do it after your residency. Like, your careers are going to be long, right? Probably 7 years or so.
Did you say 70 years?
Yeah.
70.
That's a pretty long career.
You can go strong if you're still.
They're like, get that old lady out of here.
Just making sure you're all still awake for James.
You need a blood pressure bag, she'll fall on it.
Nap time at the clinic.
Sorry, James, carry
Go
on.
ahead.
So my PDSA is along the same lines as discharge planning. Yeah.
No, it's clearly a
Yeah.
huge topic, right? And I bet that you're not going to say that all of the same
Yeah.
things. There you go.
So one thing that I found to be like a pretty recurrent sort of headache is when you're getting a kid ready for discharge in terms of coordinating follow-up plans and plans from the different like consulting services that you've had, and making sure that those are all in the right place and everything is on the same page and everyone knows where they're going. Because I think it's done a little bit haphazardly throughout the admissions day. So sometimes a consultant service will write on their consultant note that they want to see them again, and maybe they'll have a date in mind, or maybe at some point in the in their IPN note they'll write, we want to see them on this day, and then that sort of gets like transferred into the services note, but then it just like either has to like keep getting carried on through every service note, so you keep writing over and over again that Gen Surg will see on October 14th. Otherwise, it's going to get lost back in the shuffle. And then when it comes time to discharge, you have to like comb the chart to see when this service wanted to see this person. And then we do have a spot on most of our patient lists where we can say like this patient wants to be seen at this time, but that really depends on who's going to be updating it and whether whoever is taking care of that patient has thought of like taking it from the chart back onto the list and updating it so that it's in place for everybody to see. And that's just the medical side. So I know the nursing has their own way of charting and recording and planning who's going to be discharged, but I don't think there's a lot of communication between the two services, which can be frustrating too. So when it falls on the junior to sort of make those calls the morning during rounds when someone's going to get discharged and talking to ID and Gen Surg and every service that's involved in terms of what follow-up plans are going to be, I think it just adds extra time that we could really cut back on. So my intervention was creating a one-page, and we sort of already have this, so this is like one of the things that I was kind of like hemming and hawing a bit, and listening to all of you talk about your various plans for discharging really got me thinking about more ideas and like jettisoning some of my other ideas, but creating like a one-page document. And I know we already have like a discharge sheet, summary sheet in the charts, but potentially either using that same one or creating a different one, but making it a part of every patient's chart in a designated spot that is consistent across every patient's chart, that can serve as a repository of information for consulting services and allied health to write down whether they need to see the patient and when that appointment date is going to be, as opposed to leaving it to the person who's filling up the discharge summary at the end of the stay to like go through and comb that chart. So what that would entail is having that discharge sheet in an easily identifiable space, and then having it be something that people would know that they have to update on a regular basis. So the way we would start implementing it is in terms of like making sure that this is. So there's a couple of things, that we would need to do. Is that this is an intervention that would require a lot of buy-in from multiple different services and requires a lot of different people to like change what they do on a day-to-day basis in terms of their rounding. And so it would require sort of like blanketed information to basically the entire children's hospital in terms of this is something that we will be doing. So that could be done in the form of like memos, or in terms of like hospital policies that come out that can get distributed from section head down to the staff on the team. But I think it's particularly important for the admitting for the ward services, so Oak, Elm, Pine, because those are typically the ones that are going to be doing most of the discharge. So I think on like an on-the-ground level, what the intervention would also entail is that when you're doing your daily rounds, in addition to have someone who's designated to take the chart, take the paper chart, someone to take the bedside chart, someone would also be designated to like be in charge of like tracking the discharge planning instead of just like flipping over to the order sheet. And before you're done finishing rounding on one patient, you just make sure that like every consultant that's been admitted, because we typically have a list or we can go through, has been like identified, and we can check to see if they've like come up with a plan for discharge rounding. And then before or discharge planning before the end of the child's admission, you can stay on top and contact them before it's the like morning when they've been designated as someone who's going to be potentially discharged. So like I said, you would need to steps to act. So I hope the process would encourage streamlined discharge planning. We could use the same measure that Duncan and Karen were using for their discharge planning. So percentage of children discharged before 11:30 or before compared to discharged in the afternoon. The steps to execute, so you need to create the template, incorporate it in the same place in all the chart, send out the memos, the policies, the reminders to all of the services in Children's Hospital, and then particularly on the ward teams, just sending out those memos and designating that one person who would be in charge of like the discharge planning. And so just in terms of doing this, so observing, I don't know if just this measure alone